Kia ora koutou and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners. Today I am here with Professor Nikki Turner to discuss the latest measles outbreak. Nikki has previously recorded an excellent episode in 2019 which covers measles diagnosis and management in more depth, which I highly recommend. Today our focus will be on providing a brief update on the current outbreak. Nikki Turner is an academic GP and a professor in the Department of General Practice at the University of Auckland. She works part-time as a GP in Wellington and is the medical director of IMAC, the Immunisation Advisory Centre. Nikki, thank you so much for being here.
Thank you. Kia ora, Helen.
Could you start by just giving us a brief summary of the current measles outbreak in New Zealand?
Yes, sure. So as of today, the 6th of November, there are actually only 17 cases throughout the country. And as of today, they've told us that none of those are infectious. So this is a huge amount of public health work. The cases are all around the country. So we had been and we continue to be watching closely for spread. But I can report today, as of this week, the cases have not increased for the last 4 or 5 days, which is fantastic.
Do we know what that's down to?
This will be down to a couple of reasons. So the reason measles spreads is because it spreads from a person to someone else who's non-immune. So the reason, if we are getting stopping of spread, it's because the measles virus is hitting an immune barrier. That'll be down to vaccination and a lot of hard work with public health services around the contacts of the actual cases. So go New Zealand so far. We're not out of the woods yet, but hopefully it's looking promising.
Oh, that's great news. So it sounds like we're doing great things to avoid worst case scenario, but thinking about what worst case scenario could be and who's at highest risk here during an outbreak like this, could you tell us about who would be most likely to be affected?
Yeah, so the worst case scenario is when you have a population with endemic measles where there's no vaccination and essentially the entire population gets exposed and every child through childhood will get measles, and we're all aware of the huge damage from that. In a vaccinated population, the worst case scenario is the virus finds pockets of unvaccinated and spreads. And that's what we saw back in 2019 when we had more than 2,000 cases around the country, of which nearly a third ended up hospitalised. So that finally went away basically because you hit enough vaccinated people, the virus cannot spread. So remembering there are people who are at high risk, and they are those who have not had 2 doses of vaccine over a year of age, and these are infants who have been too young to be vaccinated, and immunocompromised people who are not able to be vaccinated because of contraindications to the vaccine. Those are the reasons the virus spreads. It only exists in humans. It can't spread in any other way, and we've got really clear international evidence that if you have high, consistent vaccination coverage across a community, the virus stops dead and you eradicate it.
Given the general trend towards falling immunisation rates, was this outbreak foreseeable or predictable in some way?
Yeah, there's a couple of reasons why we were expecting it to come, and we will see more outbreaks. Yes, our infant immunisation program, the coverage dropped off quite significantly, particularly since COVID. So we have a lot of infants under-vaccinated, and we've probably got 10-20% at least of our infants that are walking around under-vaccinated. So that's the first risk. The second risk is infants, children, young adults, midlife adults. There's a range of people for a range of reasons who did not get 2 doses of MMR from over a year of age. And from anyone over the age of 18, they don't always know their records. So we've got a lot of people walking around in our community who may be under-vaccinated or not vaccinated at all, many of which are unaware of this.
And I see IMAC have recently released a really excellent webinar on latest MMR guidance. So we won't rehash all of that stuff in detail, and we'll provide some links on our website to that webinar. But do you have any key messages or the most important things that you'd like us to know in primary care which can help change the trajectory of the outbreak?
Yeah, so firstly, as we all know, vaccination. First dose is counted from a year of age. Second dose at least a month after the first dose. The importance of knowing that people have been vaccinated. So if many people are coming and saying, I'm not sure if I've been vaccinated, revaccinate. If somebody is already immune, they will already have antibodies to measles. When you revaccinate, it'll just deactivate the vaccine so they don't get side effects. So it's very, very safe to revaccinate. We do not recommend serology. Serology is actually hard to interpret, it's expensive, and it's not useful in general rules in primary care. The main purpose for serology is for people who are immunocompromised or have been in contact with someone with measles and you're unsure about their status. So that's quite a small group of people. So for most of us, vaccination is the way to stop measles spreading in our community. It is absolutely fine to overuse MMR vaccination. If we have enough people vaccinated, you can protect those who cannot be vaccinated. The next strong message is that it is a live attenuated vaccine. That's what makes it highly effective. Live attenuated means the virus actually multiplies inside you, so gives you a very effective immune response, which is really long lasting. But you cannot give it to people who are immunocompromised or pregnant women. So there have already been some errors of people giving MMR to immunocompromised people. So remember always, anytime you're about to offer an individual an MMR, check that they are not immunocompromised, they don't have a significant immunocompromising condition, or they're not on immunocompromising medications. And of course, as we all know, there's more and more of the population on immunocompromising medications these days, particularly for the rheumatoid arthritis and other seronegative arthritises, and for people who are on oncology treatment and a whole range of things. So just think, is this person okay to have MMR? And do not give it unless you're really sure they don't have a compromised immune system.
Thinking about once people are immunised, does the immunisation prevent infection full stop, or does it reduce severity of the disease, or could you talk us a bit about what the immunisation actually protects against?
Yeah, so nothing's absolute in life, but MMR vaccine given 2 doses is highly effective long term. So you probably get 99% effectiveness after 2 doses, but you don't get 100% effectiveness. So some people can still get measles who have been fully vaccinated. Now, once you're fully vaccinated and you've got immune protection, you can still get mild breakthrough disease. So if you're seeing somebody with a measles-like condition who's fully vaccinated, they still could have mild measles. So don't just discount it if they're fully vaccinated. Now, what we are seeing, though, is fully vaccinated people with mild symptoms of measles, and that we are picking up the measles virus, they're incredibly unlikely to transmit. It's possible, so you have to practice all your proper PPE and protection, but it's much less likely. In fact, we've already got a case this time round with an adult with confirmed measles who was fully vaccinated, and there have been no transmission from that case. So it's possible, but less likely. So I think the importance for us is unvaccinated people, think really hard, could this be measles? Vaccinated people, still possible, don't forget it, but it's slightly less risk.
And with PPE, what are the current recommendations on how we should be protecting our frontline staff with PPE?
Yeah, so firstly, all of us as frontline staff make sure that we actually have had 2 doses of immunisation, unless we're older than our mid-late 50s. You know, the rules are if you're born before 1969 in New Zealand, similar to other countries, you were probably exposed to measles when you were young. But for anyone up to their mid-50s or probably into their 60s, early 60s, if you're a frontline healthcare provider, ensure that all our staff have had 2 doses of MMR. They're therefore then likely to be pretty safe. Now, we also recommend PPE. So if somebody's coming into our practices and we think they might have measles, then firstly, you don't want them to appear if you can avoid it. You want them to wait in a car and somebody goes out wearing preferably N95, decent PPE. Do your best to stop transmission. If it's not measles, it's still some other sort of virus. If they do come into the practice, then you really don't want them sitting in the waiting room with other people, particularly immunocompromised and infants under 1. So those are the people who are going to be at particular risk. So just think, how could I manage my practice scenario if somebody appears without saying to me, I think I might have measles?
When someone is triaging patients with, coryzal symptoms, what sort of particular questions are you asking to risk stratify whether they need to be seen out in the car park or in a different setting?
Yeah, well, firstly, you'd want to know if they were fully vaccinated against measles. If you've had 2 MMR doses, then you can be a lot more relaxed that even if it is measles, it's much less likely to be transmissible. So that's the first question. The second question is you can even over the phone ask the symptoms. Yes, they're coryzal symptoms, but does this kid have red eyes? Do they have a really chesty cough? They have a rash? Where did it start? Now, that's not going to screen people for or against measles, but it gives you a bit of a pointer. Do they have a high fever? If they've got just a traditional runny nose and a bit of a cough, but they don't have really red eyes and a high fever, then you're less likely to have measles.
People who have been close contacts, they've all been informed at the moment, and they'd be able to tell us if they were at higher risk because of known contact.
Yes, that is correct. The public health services are doing a lot of legwork. So the moment any of us see a case we consider measles, yes, we take a swab, but we inform the public health services straight away, and they will jump in and they do a lot of active public health advice to the case and to contacts of the case. So I think that's a good point to talk about MMR 0 too, because at this stage in the country with only 17 cases, the advice in the country is children under a year of age, we do not advise offering an extra dose to. So MMR 0, as I'm sure everybody knows, is giving an extra dose to children under 12 months of age. Sometimes under 12 months of age, it's not as effective. And it can also sometimes interfere with MMR 1. So we don't want to rush in and give MMR 0 quickly. So we would wait until there was a local outbreak and it was important. And then the local public health services would say, yes, please start recalling your infants from 4 months to 12 months. At this stage, we can reassure the worried well that children under 12 months are not likely currently to be at high risk. But of course, for infants under 12 months and all those parents who are anxious, what you want to make sure is there's a wall of immunity around them. So you want their parents, everybody around them to be vaccinated. If they're going to early childcare centres, you want to know that all the staff at the early childcare centre were vaccinated. I think those are perfectly valid questions. This is trying to put a ring of immune protection around those who can't be vaccinated. So MMR 0 is effective. We know it has effect from 4 months of age. It probably slightly blunts the effectiveness of MMR 1, but then you've got to make sure you go on and have MMR 2 as well to ensure a good immune response. So it's probably fine, but there's reasons enough not to rush into the extra dose under 1 at this stage.
And is that MMR 2 then again at 12 months, or would you offer a vaccination 4 weeks later?
Yeah, so if you'd given MMR 0, you give MMR 1 at 12 months and you continue to give MMR 2 at 15 months. That's why it's called 0, because you still need dose 1 and dose 2. Yeah, so you've got to get the 2 doses in still. And that applies if some infants have been getting MMR 0 when they're travelling to areas with measles. They still need 2 doses when they come home.
And if people have been born before 1969 and they are wanting to provide this ring of protection around a newborn or someone, what's your approach to that? Do you still recommend the vaccination?
Yeah, I know there's a lot of anxiety in older people about whether they could have measles. Firstly, we are not seeing any cases of measles in people over 70, and we didn't in the last outbreak. So I think we can confidently say if you're over 70, you're okay. Now, if you're mid-50s up to 70, you are probably fine. We see the very occasional case in those ages. So if somebody grew up in an area where they feel like they may not have been in contact with measles and they don't remember ever having MMR, particularly if they're a frontline healthcare professional, it's not unreasonable to vaccinate somebody who's maybe in their late 50s, early 60s. But as a general rule for our public, reassure the older people, focus on getting MMR rates up for the young children, the infant, and then moving into adolescents and young adults. That's where the gain is.
So if someone is in our clinic and we suspect that they may have measles, what are our next steps?
Right. Well, firstly, make sure you've got PPE immediately, that the person is well away from anybody else they could be exposed to. So just make sure your environment is safe straight away. Move them out of big public areas, put them somewhere safe, and then ring the local public health services and then take a viral swab.
And if we've got a staff member who is pregnant or immunosuppressed, we worry about them having been exposed. What do we do then?
Yeah, so remembering if a pregnant person has had 2 MMRs, they're still probably pretty safe. They're unlikely to be at risk. But obviously, everybody who's pregnant is always slightly worried about that. But immunocompromised people, you do want to keep them away from respiratory illnesses as much as you can. It's very hard for frontline staff. Now, if somebody was unfortunately exposed to measles, who's at higher risk, remember there is HNIG, the immunoglobulin available for somebody who can't have the vaccine and might be at higher risk. So they are using HNIG for pregnant women who may not be immune, and particularly for immunocompromised, and for young infants, particularly under 6 months of age. Now, for others, like infants 6 months to a year who might have been in contact, or people who can't remember their immunisation history but have been in contact, get MMR into them as soon as possible. So, if you've been in contact with a measles case, or even if you think it's a measles case and you're not sure about somebody's MMR status and there's no contraindication, vaccinate as quickly as you can. If you get in within 3 days, it could well be effective.
And sorry, that's for people, it's even for kids under 1 year old.
Yeah, particularly if they've been in contact with a measles or a likely measles case. That's when you can use MMR under a year of age.
Cool, thank you. Some questions, I guess, about broader context. In 2019, how did the outbreak actually end, or how do we measure containment?
Yeah, so it basically ends when you've had cycles where the virus hasn't continued to perpetuate. So if you see 2 weeks and it hasn't come, and then another 2 weeks, another 2 weeks, you've had 3 cycles where you're not seeing the virus. It's basically hit a wall of immunity and the virus is no longer able to spread. So it just stops. And so New Zealand at that point stopped community transmission. And then after that, it comes back because it returns from international spread. So up to recently, the only cases we were seeing were international arrivals, in which you can say, okay, that'll stop because it hits a wall of immunity. But the problem we had very recently is we started seeing community transmission. That's what now we've got to wait 2 or 3 cycles of a couple of weeks each to see that it's going to stop dead, because it's not finding non-immune people to spread to.
So it's an incredibly vaccine-sensitive infection, and essentially with vaccination rates up would be non-existent in New Zealand.
This one is a linear conversation. It's amazingly vaccine-sensitive. And we know that the world should eradicate this, that you get high enough immunisation coverage, this virus cannot spread. Humans are the only host. The Americas had completely eradicated measles for a long time, until I think it got reintroduced to Venezuela and the health services were poor, and it takes off again. So the world should eradicate measles, and it's just the problem. It's a health service delivery, and the virus comes back and spreads. And as we all know, the world's in a bit of a parlous state at the moment. So we're not looking like we're going to get international eradication for a while yet.
What impact on overall vaccination uptake do you think that this latest outbreak might have? Are you hopeful that it may encourage people to rethink some of their decision?
Yes, it does encourage people to think. I mean, obviously it brings out the worried well who are already vaccinated, but it does encourage people who hadn't thought about it to think. I mean, the problem with vaccine-preventable disease is always out of sight, out of mind. And we have a population, many of whom have never seen measles. So it does require sometimes a bit of the fear factor to help people to respond. And so we are seeing a big uptake in vaccination. So good on everybody out there who are vaccinating. It does make a difference.
Thank you so much, Nikki. That's been really informative. What are your key take-home messages for our listeners?
Yeah, so the key messages are vaccination is the way to eradicate measles, and we will eliminate it with vaccination. Start with your 1-year-old, start with your infant program. Make sure you've got everybody up to date in the infant program. If we've got energy and resources, focus on the kids, the adolescents, and then the adults. But I know we're all resource stretched at the moment, but at least start with our kids if we can. Remember, it's a live attenuated vaccine. Do not give this vaccine to somebody who's got significant immunocompromise. If you do accidentally do that, seek help, because you could use immunoglobulin to protect that person. The importance of protecting those who can't be vaccinated, a strong message. Infants under 1 at this stage, immunocompromised and pregnant women. So we want to ring protect those who are at risk. There's quite a lot of immunocompromised people in our community walking around looking well, but they need looking after. So this is a community protection. If you think you're seeing measles, ring the local public health services and look for help. And remember, if you do get exposed and you're at high risk, we do have human normal immunoglobulin available. So good luck, everybody. Do the best we can in our constrained times. But, we're out there vaccinating everywhere, and good on general practice.
All right. Thank you so much for your time, Nikki. If you're a New Zealand GP and would like to claim CPD points for listening to this episode, our podcast is eligible, so please log them. And you'll find links to the resources that we've discussed today on our website at goodfellowunit.org. If you would like to get in touch, we do value your feedback, so you can email us at podcast@goodfellowunit.org. Thank you very much for listening.